thoracic 2-level Deuk laser disc repair at T2-T3 and T5-T6. But you're sure I did the PCDF, right, Luis? I think it's going to be right around here. Shot? Let's try, actually here. Shot? Let's try here. Are you comfortable? Oh, no, I need num num.
Don, how you doing?
We're going to give you a little numbing medicine.
Shot now, Don.
All right, little numbing medicine. I know it burns a little bit going in. I apologize. Yeah, I know, it's terrible. Just give us a minute. We're going to get you feeling a little better. All right, so that's, you have any more of this?
Oh, yeah.
Actually, so yeah. So if that's 2-3, 2, 3, 3, 4, 4, 5, 5, 6. Did you mark out 5, 6? Shot? Shot? I think that's 2, 3, 4, 5, 6 is the one below right here. Shot? Probably there. Okay. So I'm going to give a little more numbing medicine. It's all on the right side. Everybody agree? Yes, I know. It's just numbing medicine. That's all.
Keep your head still, really still. Like we talked about, real still, Don.
All right. So our patient has herniated discs in his thoracic spine. They're painful, and we're going to try to fix that today. Where was the injection? I think it was lower here.
This one 5-6 and this one right here.
Yeah, the other one was further up. It's right there. Mm-hmm. Sean, probably want to be a little bit higher, but it's hard to say on that view. Let's go ahead and verify where we are by going down to T12. Lay still. Don't move.
Just relax, Don. You're doing great. Slow, deep breath for me, okay, buddy?
Shot?
Nice and slow, deep breath. Let's put some ones around.
Really? That's the best we can do? You're going to have to open the field up a little bit.
Okay, you all right?
Darken it.
Pat it and relax.
Shot? There's 12. I mean, we can't do better than that. Can you get more penetration? Come take it off pulse mode. I've got to be able to see the ribs coming in. Shot? You're gonna have to do something, Jordan. Can you pulse and take it off pulse mode? Did you take it off pulse mode? And that's a non-pulsed X-ray? Wow. I need you to take another shot. We got to get moving here. This is horrible.
Try to stay still, my friend. We're X-raying, all right?
Lay still.
Stay still.
But definitely I did the PCDF, right? Keep going, Jordan. You got to keep going until you get this better. I don't think coning down is helping you. I think you need to be able to identify the ribs from the side coming in. So you need a wider field of view. You need better penetration. That's too wide. Why would you go from one extreme to the other? This is just wasting time. Come on, be smart about your decisions. See, that's perfect there. I just can't tell if there's another rib down below. Go further down. Shot. I can't tell if there's another rib coming in. Can you, Luis? All right. It looks like there's a rib there, but it's really hard to tell for sure. All right, well, we should be able to count from up higher. All right, I mean, that looks like 12 there. That's better. So let's see if we can count up. Go up a little bit. North. Twelve, 11, 10, 9, 8, 7, 6. It looks like 5, 6, right? So let's just count these pedicles. That's the best we can do, right? Jordan? 12, 11, 10. Let me see if I can get 10. Shot. 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 12, 11, 10. Now go north just a little bit. 10 would be below. 9, 8, 7, 6, 5. 5, 6 is that disc that's sticking out. So, all right. Let's go back up to that 5, 6 area. I'm going to place that needle first.
Okay, Don, hold on a second. We're just getting you in the right position. When you move around like that, you lose your position here, Don.
2, 3, 4, 5, 6. Yeah, 5, 6. Don't move.
Stay still.
Shot. That looks good. All right. Let's give some numbing medicine. I apologize for the x-ray machine blocking your view, but there's not much I can do about that part of the surgery. We have to just do the best we can.
Of course.
Our target will be the 5, 6 disc first. Let's go to a lateral view.
Try to stay still, all right, Don, for us? Thank you. Head nice and down and low. Arms and hands not moving at all.
All right, so that's 2, 3, 4, 5, 6. Looks good. Probably could be a little bit more lateral. Shot. 2, 3, 4,
Head down, buddy.
5, 6.
Head down.
Lay still. Shot. All right, yeah, that's better that you reduce the exposure. 2, 3, 4, 5, 6. I need to be a little bit further south. It's amazing how low 5, 6 is on him, huh? Shot. All right. Give me an AP. How's he doing on ventilation? 2, 3, 4, 5, 6. We're doing 5, 6. Everybody agree? I think I'm too medial, which is fine. I'd rather air too medial than too lateral. AP? Yeah, we're too medial. And let's go back to a lateral view. Just lay still. You're doing great. So we've got the right level. We just need to 2, 3, 4, 5, 6. Shot. 2, 3, 4, 5, 6. You agree? Let's go with another AP. Quick AP. Okay, so we're still a little too medial, which is okay. Let's go back to a lateral. 2, 3, 4, 5, 6. Yep, that's good. Not too bad. We're close. That's his facet joint shot. Yep, 2, 3, 4, 5, 6. So I want to come back a little bit. Are you okay?
How you doing, Don?
Shot. That's better. Shot.
Yeah, he's setting fine, and his own title looks great, and the waveform is perfect, but
Shot. Let's get an AP. So we're now lateral to the spinal canal. We're just lateral to the facet joint, heading towards the 5-6 disc. We know that because the screw at the bottom there, if you look up near the top, that screw is in T2. T2, and then the pedicle below is 3, then the pedicle below is 4, then the pedicle below is 5, then the pedicle below is 6. So we're at the 5-6 disc space. Yep, lateral. It's looking good. The kind of things that are making this surgery very hard is the patient has some scoliosis. He's got bone spurs. His facets are enlarged. He's obese. I mean, I'm obese, so hey, whatever. It is what it is, but he's big. He's got, his bone is a little bit, I think, osteoporotic, right? I mean, you can't see it that well. So we're fighting a lot of things. Lay still, you're doing great. And we're clear of the lung fields. Shot. No. Just lay still. Why is he moving?
keep that head down. Head down.
Try to stay still, my friend. No, put your head down. Keep your head down. He's really squirmy.
I know he's squirmy.
I think he's had that in the last 5 procedures too.
Had what?
I read the chart.
Yeah, then
Had what?
Just moving all over.
Squirminess?
he's the hardest to date because
Very difficult.
it takes a lot. Yeah,
Where do you feel it?
where do you feel that?
Don't move. All right, that's great.
Center.
Yeah, that's where your bad disc is. That's what we're after. We're in. Wow. All right. Well, you are watching history, folks. Not this particular surgery, but this technique that we're doing is a thoracic disc herniation with a minimally invasive endoscopic transforaminal approach. Lay still. Of course, our patient's awake. They're going to move a little bit. That's normal. Don't freak out about it. That's beautiful. Absolutely beautiful. All right, now we're going to go for the next disc, which is higher up, and that is the T2-T3. So what happened was he had a fusion done of his neck. You can see the hardware up there, screws, rods, and that adjacent segment disease has developed. He has a herniation at T2-T3. Lay still. You're doing great. Whatever you can do to help me. I'm okay because I can get a moving target. But whatever you feel you can do to help us out.
I want him to report the discogram.
Absolutely. Yeah, I want a discogram. So I'm not bothered by this as long as he's strapped in well. So 2, 3, I can see the 3. Shot. It's too high. Shot. That's probably right about where we need to be, right there. So I already numbed them up there. All right, any questions from our audience so far?
No current questions.
Blood pressure is good. Give a little num-num shot. Yeah. You know, so, and of course I didn't mention squirreliness, but when the patient's moving around a little bit because they're not quite asleep yet, we're going to put them to sleep soon, but not yet. I need his help right now. How you doing? All right. So, shot. Just lay still. You're doing great. Let's go lateral. So on the AP, it looks perfect. We're going right for that pedicle below T3. Below T2, which is the T3 pedicle. And it's the disc space right there, the T2-3 disc space. Everybody agree we're doing T2-3? Yes? All right, there it is. All right, I may want to start a little more north and bring myself into a north to south trajectory. I probably could go a little more north. Give me some local. Is he doing okay?
No, we're just looking up his EKG came off.
All right, but he's fine, right? Stable? Okay, I'm just going to start a little bit higher. So I'm giving him a little numbing medicine there. Lay still. And the reason why we broadcast our surgeries live is so everyone can see how they're done, the challenges we have to overcome, okay? And also what's possible in this day and age. What can be done? Is fusion the only thing, or are we able to fix people without fusion? Let's give a little more numbing medicine. Shot. That's perfect. Yeah, go ahead. Put it on. So right now we're in the muscle, just behind the spine, and we're going to give a little bit. Lay still. Still give him a little bit. That's good. You feel some going? A little more. Yeah, good. Perfect. So the patient needs to be awake to help guide me. I'm wanting to avoid any type of contact with the spinal cord or any contact with the nerve roots. 5, 4, 3, 2, 2, 3. Lay still, you're doing great. I think I need to be a little bit more rostral as well. You think he's just, I don't think he's in pain. Shot?
I don't think he's comfortable on this bed.
He's not comfortable in the bed? Yeah, I agree with you. He's saying his hips are bothering him. Laying there.
Hurting him, his chest is hurting him, everything's hurting him.
He's just sore. Well, let me see what I can do here to
Baseline, he does take
move things along.
prior to sedate.
Shot.
He has brought a CPAP machine with him.
Shot. Yeah. I need to see that C2-3 better. Lay still.
Stay still, buddy. Try to stay
Let
still.
me have some num-num.
Yes, sir.
This is his arthritic facet. Lay
Gotta keep your
still.
hand still. Hey, Don. You gotta keep your hand still, Don. Don, you know who you are? Don.
Also, you guys can ask questions to us while you're watching the surgery. So, shot. All right, I'm hitting up against the facet. I want to be a little bit more lateral. Shot. I don't know.
Hey, keep your arm down.
You think that's what it is?
Yeah.
Shot.
Well, that affects pain threshold.
Shot. Shot. Hey, get an AP. All right, we're close on the second needle positioning. The first one I'm very happy with. That's 5-6 down there. I just want to get this one in and we're close. Yeah, it's looking good. Back to a lateral, please.
Keep your hand still.
Is he moving his wrists on the arm board? Yeah.
Keep your hand still. No, you're doing great.
Shot.
There you go, buddy. Okay, just relax.
Mm-hmm. The trajectory looks really good. I just need to be a little bit more lateral.
Okay.
Do you have the AP shot? Mm-hmm.
Done.
How you doing, buddy? You all right?
Shot. Ventilating good. Shot. Close. Real close. We need to be a little bit more lateral. Anything you can do, Dr. Berndes? Shot? No. I'm not moving anything and he's moving. Oh.
I'm gonna try like him. Maybe he's disoriented. Hey,
Shot?
Don, can you hear me? Don, can you hear me? Yeah. Okay, you're moving a lot. You're moving too much. I need your hands still. Look, this hand still.
Shot?
Loosen up. And that hand still. Keep your head down in the cradle like we talked about.
Mm-hmm.
Okay, you're
Lay
moving
still.
too much. Head down. You're moving too much. Okay?
Yeah.
I'll give you much more sedation.
This is not a pain medication issue. This is a non-cooperative issue.
Well, I wanted to see if he was in a disoriented state, but he's not. He's responding appropriately.
No, I'm not so sure.
What?
I mean, don't know that he's responding appropriately.
Don, you're moving too much, okay? All right?
Is that the latest shot? Dawn? Shot? Shot? Do you have him a little more awake? Shot?
We're doing that now.
Uh-huh. That might help.
That's what I'm thinking.
We're so close. I just need a moment to
Hey, Don, can you hear
a
me?
moment of reprieve and I can get this, but his facets are very arthritic. You can feel all the arthritis on the facets. Shot. Trajectory looks good. We're just a little bit too medial. Shot.
Done.
Keep your head down, okay, buddy? Hey, Don, you're moving too much, Don. It's Dr. Berndes here. How you doing, okay? You're moving way too much, okay?
Don't move.
You gotta keep your hands and arms really still. All right, remember what we talked about? Don?
Here we go.
I think that's the key.
What's the issue? Yeah.
Might have gotten all of this for it. I don't know.
Lay still. You're doing good. We're just almost there. We need you to sleep. I mean, we need you to stop moving so we can put you to sleep. Huh?
He's like a really strong muscle.
Okay, okay, keep that head down. Remember, like we talked about, you can get that head nice and still. Almost there.
Yeah, I just cannot
Just go nice and still.
Nice and slow.
get
deep
around
breaths.
this
Slow deep
facet.
breaths, Don. Okay.
Well, you have him fully awake yet?
Yeah.
Can you see if he can just lay still and respond appropriately?
Don, can you hear me? Yeah. Okay. Don, Dr. Deuk is operating right now. Can you lay really still for us? Can you say yes or no? Yes or no? What? He can't. He says he can't stay still.
Why not?
Put your head down.
Hold your head still, please.
Why can't you stay still? Are you uncomfortable on the bed?
Yep.
All right, you're going to have to just fight through that discomfort if you want to get this done. Just control yourself. I know it's uncomfortable. Your hips are uncomfortable, but I can't operate with you moving around.
Slow, deep breaths. Keep your hands and arms.
Yeah, you're doing good. We're almost there.
Slow, deep breaths now. Breathe in and out for me. Slow, deep breaths. In
See,
and out.
it's just too much arthritis right there. Shot, come on. That looks better, but I need to be more lateral. All right, try one more time. A little bit more lateral.
I'm trying to take them deeper, but it's sleep apnea.
No, but I think he needs to be more awake. That's the
Okay,
problem.
put your head down. Good job. Keep your head down, Don. Don, head down.
You're doing great.
You're doing great.
There's only one way a human being can lift themselves up. That's by pushing on their elbows.
His elbows are secured and they're padded. You've got him padded here, secured there. And he's on board the whole time.
Is he pulling his elbows down to his waist?
He's trying to get him holding.
Yeah, don't let him
He's
do
pulling his
that.
neck up at the same time as he pulls the elbows. So he's just
Yeah,
showing
but
balance.
that's... You okay? Hey, he's doing better. You're doing good. We're almost done. What? We know.
Longer, okay? Do the best you can to fight through that.
I see we're in a perfect trajectory. Just need to be a little bit more lateral.
Okay,
Don't move.
head down.
Don't move, head down.
Shot. Yeah, that's your arthritic facet joints, my friend.
Yeah.
That's all right. You're fine. It's just your arthritic area. Very
You're doing great.
close.
Hang in there. Keep your arms and hands real still, okay? Elbows still, everything still.
Shot.
Don't lift
Head
your
down.
Don't lift your head.
Yeah, I know your
What is
chest
it?
hurting. You keep saying his
Just
chest is
focus
hurting.
on deep breath.
Just where he's laying, it's hurting. Trajectory looks good. Again, the facet shot. Any way we can get better visualization in that area?
Yeah, hold still down.
Jordan, any way you can show us that area a little bit better? Yeah, you're overexposed at the top. It's brightening everything up. Let's see if you can get it less exposed. Okay? Darken it up a little bit.
Hold that head nice and still. Keep your shoulders relaxed.
Wow. Did he move it that much? Jordan, do you see where we need to be? So that's where I need you to show me that area. You're probably going to need to move the 40 north. I shouldn't have to tell you that. can you, that pedicle looks pretty good at T3. That's looking better, definitely. Shot? Where are you having pain? Shot? All right, that's actually pretty good. That's where we need to be. Shot? AP, you just lay still, we're almost done. You stop moving and finally, no, don't move. You don't move, I'm asking my technician to move the fluoro. That's good. That looks really good, actually. Good. All right.
We try not to move though, just bear with it.
Is it pressure there? You have something pushing on it? He was complaining about that before, right? Go lateral. Oh, you're talking about the cushion.
Yeah, just pushing on.
It's the cushions that are bothering you? Will you verify that?
Where does it hurt you?
After the under the back and you check his chest under without pushing anything, go down there and check the
The padding is pushing on him? Why do we choose this table?
first the weight, huge bit. Yeah. The other one is 350. He came before with 350 pounds, so I don't trust him.
Okay, we're almost done. If you just lay still, we'll be done. Huh?
Just the body weight on the chest.
Shot. I mean, it's looking good on the lateral view. Shot. All right, AP. Almost done. You're doing great. Where's blood pressure?
Okay, Steve, keep your head still.
Lateral looks really good there. Come on, Jordan.
You're doing great.
Can you try to center that? Is that centered? Can you get a better shot than that? What's wrong?
Just the monitors. When you move, the monitors.
All right. Yeah.
What's going on?
Lay still. I'm not gonna be able to get 2-3. It's just not allowing me. It's too risky. Are you comfortable?
No.
All right, let's just see.
Yeah, if you have it, let's do the machine. Laser. Thank you very much. Thank you.
Oh, we have no dye, right?
Yeah, all right.
Okay.
All right, let's go ahead and put them down to wherever you feel comfortable, and we're gonna get started. Are you able to do that or not?
I'm gonna try my best. I'll give you that. I'll try my best. Super difficult.
Well,
Super.
if we can't do it, we're gonna have to bring them back and just.
Records of all of it's just not easy. People don't change. Personalities don't change. Body habits didn't change at all. That's most things.
What do you want to do?
Give it a try. You're already there. You're found the right. Give it a try.
Yeah, I feel really good about 5-6. It's just 3 I'm not able to get because he's moving around so much and. Huh? I need a lateral. Yeah, he's got facet arthritis. But really the biggest problem is just the moving around too much. Huh? Yeah, that's what I'm saying. That's what I'm saying is if we have to intubate him. We're going to have to bring him back.
Yeah, it gets a little risky, but we'll do our best to keep the tidal lines as best as we can.
At least we'll do this one right now. As long as you're comfortable with him.
If he's moving around too much, we'll just
That's fine, yeah. Shot?
board it and come back and do an intubation.
That's fine. I mean, I'm here now. I want to get 5-6 while we're here.
That's the safest way.
But if you feel we need to stop, we'll stop. How's blood pressure? Can we, I mean, I'm okay with it, but can you bring it down just a little bit? Because he is hyperdynamic. All right, we're making our incision. We're going to treat the number 5-6 disc. That's the one that we're in, and we tried to get the 2-3, but he just kept moving too much and couldn't get comfortable. And we've done everything we can do to try to access it with him awake. The only other thing we can do is bring him back and intubate him under general anesthesia and try to do it. Didn't want to do that because of his respiratory status and the lung fields and a variety of other reasons. I like to do these with the patient that is awake so they can give us feedback, but he's really not cooperative. Some patients don't do well with awake anesthesia. This is one of those patients.
All related to their medical conditions they bring to the OR.
Huh?
It's all related to the medical conditions they carry with them to the OR.
You think it's the medical conditions?
100%.
Is there a specific medical condition that's particularly bad?
Diabetes, morbid obesity,
Okay.
structural obesity for laying in the prone position,
Yeah.
obstructive sleep apnea.
And he's got pain in his hips, arthritic pain. Yeah. You okay? We're almost done. We're doing our best to keep you comfortable. Not yet. Let me try to bang it down. So yeah, he's got a lot of comorbidities as we're talking about that basically make it very hard to do the awake surgery. Yeah, I think we're okay.
Yeah, let me know.
All right, you're all right. We're inside your bad disc. And I'm sorry you're not more comfortable, but we're trying to keep you safe and still get your surgery done. Well, this is why we broadcast, so everyone can see what we really do. And, you know, this is not bad, by the way. I mean, you should see other types of surgery. It's far worse. We're trying to do our best to keep him comfortable, but there's a limit. You're doing great, by the way. We're almost done. That's your bad disc, I know. Good news is that pain will be gone when we're done. All right, we're inside the disc with the tube. We're going to take the dilator out. And, you know, I could try to do a little bit of local in there. I don't know if it'll help. Not that local. Lay still, you're doing really good.
Head down, head down. Did you grab a bag of fluid? Thank you.
Oh my goodness. Do you want local or this one?
I want the usual that we inject, the num-num.
So this
Come
one
on.
is lighter only. You want this?
Whatever we normally do for num-num, for the muscle and soft tissues. Not, I don't want epinephrine.
No,
Yeah,
no.
that's
So
what I
this one
want.
is the one that,
This is what I want.
request the other one.
Like I said, I don't know how much it's going to help, but all right. So this is a thoracic Deuk laser disc repair. It started out, it was going to be 2, but we're not able to do the other disc because the patient is not really cooperating, and we need cooperation to do the surgery. So we may have to try to bring him back afterwards and just do it under general anesthesia. How you guys doing?
Come on, please. Thank you.
How are we doing over there?
Oh, having a blast.
Are we safe to proceed?
Very good. Very good.
Okay. All right. Here we go. There's the herniation. couple of pieces already want to come out. Do we have anything we can wrap there? To keep the fluid controlled. Is we're at 20, right?
Yes, sir. 20, right? 20 watts? Yeah.
Like even when he's had
Okay, good.
rhizotomy, so like he had someone laying on his back once. And
He had someone what?
When he had a rhizotomy, he had someone, I guess, like trying to hold him down, and he just like
He has a long
basically
history.
got up off the table.
He's not a great candidate.
No.
Can we turn on these lights, please, sir? Thank you.
Uh,
We're gonna need a.
all right. Any questions from our audience?
No kind questions.
All right, very good. Well, we are inside the T5-6 herniation. At least we're going to get one of these two treated.
Don, hold still, please. He's working on your disc.
You're doing great, buddy. Stay still.
Guys, he's in surrender, right? With his elbow is at 90.
Oh, yes. Added and
The surrender is the key to not having him come off the bed, if it's done properly.
350. I mean, he moves a little bit. He's off.
And he's incredible.
Oh, look at that herniation that just popped out. That was so cool. There's a piece. Wow, there's a lot right there. Yes, I know. Yeah, we're getting it out. Just call me the pimple popper. This is like a pimple of herniated disc.
Surgical skill level's a little different.
What's that?
Yeah.
Surgical skill level's
Just a little bit. Yeah. A little higher for the.
Well, it's yeah. It just, it's under pressure and it pops, and I just think of pimples.
Thanks, Sarah.
It's all inflammatory. So, she's got a lot more followers than me, I'm sure. I'm not as popular. I'm only doing spine surgery, not popping pimples.
You need to show more blood.
More blood and guts.
Yeah, that's what people like. Yeah.
I'm sorry, I
That's what people
can't.
like. They like all the pus.
Right? Look at the breathing, how the breathing opens and closes the hole there. That's breathing, guys and gals. Pretty cool, huh?
Yeah, that's
We call that, that's why coughing and sneezing goes straight to the disc. And it's called Valsalva. And you can actually see it in the disc. So,
We have a question from Miguel on Facebook.
rock on. Let's do it. Don't move your elbow, Gail.
Miguel asked, why does it hurt so much?
Why does it what?
Why does it hurt so much?
All surgery hurts, Miguel. You can't do surgery on somebody without it hurting. The reason why you don't see it hurting the people is because they're asleep. We can't put this patient too much to sleep or he'll stop breathing. He has a very, very difficult airway. So everybody's a little bit different. Some people we can put more to sleep and some people we have to put less to sleep. He's a less to sleep kind of person. So the amount of pain is the same for every surgery. It's just there's no response because we shut down the brain with anesthesia. But when you shut the brain down with anesthesia, the deeper you go of shutting it down, the less drive there is for respiring, for breathing. So we don't want to stop this guy's breathing. He has sleep apnea, and if we stop his breathing with the anesthesia medicine, then he's going to have a real hard time. He may not breathe anymore. So we want to avoid that situation. We have to give him just enough to keep him comfortable. Comfortable enough to do the surgery. Most of our patients we're able to put deeper asleep, but some patients we can't. because of their sleep apnea or narcotic dependence. There's a lot of factors. One of the big ones is the use of marijuana for pain control. I'm not saying this patient does that, but my anesthesiologist has informed me that people that use THC, right? Huh?
THC, Klonopin, and
THC, Klonopin, and a history of what?
narcotic use.
Narcotic use, like lots of narcotics for years.
Yeah, those are the three things that make sedation very complicated.
Those are the three factors that make sedation of these patients very difficult to do because they stop breathing too easily. So we have to be very careful in those types of patients and really minimize the amount of anesthetic we're giving. Yeah, we're almost done. This is the bad part, I know. You're going to be happy when it's all over. You can see the herniation right here, the tear and the inflammation, scar tissue, calcification, all that junk. Almost done. I need 5 minutes. So we had to abort the T2-T3 disc because the patient kept moving too much. We're going to have to see if he wants to come back and do it under general anesthesia, where he's completely out with a tube. That creates a little bit more risk for the surgery, but he'll have to decide if he wants to accept that risk or not after we do informed consent with him. But right now, everything's going well for this disc. We should be done in just a few minutes. Good question, Miguel. Thank you for asking. By the way, the only place in the world you'll ever find this surgery done is here in Deuk Spine Institute in Florida. This is an endoscopic transforaminal thoracic surgery. We're the pioneers, the first ones to do it. There is another type of endoscopic surgery that's done through the chest with dropping the lungs and going next to the heart. It's very dangerous. We don't do that. This is much safer, and it's outpatient. Our patient will go home today. Almost done, just about out of the disc. You can see the last of the herniation. You can see the inflammation right there. You saw that red stuff? I just blasted it with the laser. This is a 0.5 millimeter laser fiber, by the way, in case you're wondering. 0.5 millimeter from side to side, that glass part down there. Not even a full millimeter. All right. 2 minutes. Look at that piece of herniation just bubbling out.
Maybe if it's that ready, Jordan would be able to flip them quick.
Does he need to be flipped quickly?
I just think it'd be best.
No, he's fine.
He's fine, right?
He's fine.
Yeah. No rush. Just lay still. You're doing great. This is the more painful part of the herniation, I realize. Good. Coming out a little bit more, and we should be just about done here. Berndes is going to have to go home and have a martini. Am I right? Go have a hot tub. This was a tough one.
Yeah, I got my jacuzzi working.
Good.
I'm over.
It's so old. Cool so old.
Aw.
It's not gonna overshut up.
Better than mine. Mine's just a hole.
At least it's a pool.
Mine's just a hole right now.
Yeah.
Should be. That's it right there. See the edge of the dura? See the edge of the dura right there? Pretty cool, huh? That's where the spinal cord is in there.
Okay, hold still, hold
Yeah, he
still.
doesn't like that. Just one more on the side and we're done. We have everything ready. Let's do the betadine.
Yes, sir.
Uh-huh. We're done. I'm coming out 5 seconds. 4, 3, 2, done. Okay.
Lights on, please.
Well, I'm sorry we didn't get to do both discs, but we tried and had to abort it. The upper one because the patient was just moving far too much. And we're going to have to see if he wants to come back and do it under general anesthesia. Yep.
Okay.
Just lay still, we're done.
Almost done.
Ready? You have that roll? Give me the rollie. I'm going to show you this, guys. In just a minute, I want to show you the incision here. Okay? This is a thoracic herniated disc. Lay still.
All done. Just look at it and
You're done.
Kick that scope out of there.
Come on.
What do you need, sir?
I'm just looking for something, don't worry. Now, can you hear me? Any?
Yes.
All right. So to fix herniation here, normally you do a laminectomy infusion. You'd be looking at a cut about that big and then screws and rods. But we did it all through a tiny little incision with just a couple of drops of blood. You got it? Lay still. We got to put your bandage on. Patient was awake with some sedation. And any more questions from the audience?
No current questions.
So this will fix the pain he has at T5-6, but we didn't get to the T2-T3, so he's still going to have T2-T3 pain.
Hey, Don. We're just gonna put a bandage on. Hold still for another 2 minutes, okay? Yeah, I can bandage, yeah. Yeah, okay, just relax. You're all done.
You're all done. Done. You're all done. Damn, he's done. You can speak to him.
Go ahead and type up questions you have for me. I'm the surgeon, founder of Deuk Spine Institute, pioneer of the Deuk laser disc repair, which you just watched. It's a transforaminal thoracic annular debridement and removal of herniation. At T5-6, good work everybody. Jordan, tough case. You did good. I'll come answer your questions. It's Dr. Ari Deuk-Majan at the Deuk Spine Institute here in Florida with one of my patients who had the Deuk laser disc repair for a back injury, and it was around 6 to 8 weeks ago. And you're back for a checkup. How are you feeling today?
I feel wonderful. I feel great. I feel fantastic. I mean, this is the man. He's the man.
Well, thank
And I
you.
came in with a lot of pain, a lot of pain. I couldn't believe it. And now I'm virtually pain-free. It's unbelievable.
How long did you have your back pain? How did that start?
Oh God, that happened many years ago at work, at least 20 plus years. And I had other surgeries in the past, and they really didn't help. And this last one, it just got so bad that I had to do something. So luckily, through the grace of God, I came here, and
Amen.
yeah, and I'm A1 now.
Awesome. So you had your surgery, you've been doing therapy. Would you say the pain you had in your back before surgery is still there, or is it gone?
Oh, it's gone. It's gone. I have little twinges now, but they're muscular, and that's which is fine. That's going to go away over time. But my God, what a relief. I'm ready to get back out there and do all the things I used to do, man. It's kind of exciting. It's kind of fun.
Well, it's important that people understand too, when you have 20 years of chronic debilitating back pain, what happens is the muscles in your back shrivel up and atrophy because you're really not active anymore because it hurts too much. So, you know, we can fix the spine pain, but it's going to take time to rehabilitate the muscles and get them back to normal. So I'm glad we're touching on that. So what does your life look like now that we've gotten rid of your back and leg pain?
Well, yeah, I'm going to go back to what I've always done and what I've always enjoyed doing, which is my automotive hobby. And I'm really looking forward to being able to actually lift things again and getting the contorted angles that I used to get working under cars and stuff. It's just gonna be nice. Quality of life is it's
Not too soon with any of that lifting engines.
all right,
and
all right,
contorting your
all
body.
right, yeah, all right. But I have, all kidding aside, I have noticed over the years I developed a way to walk, almost a crab walk kind of thing, and I got used to it, and I got, well, that's the way it's going to be. I don't have that now. I mean, it took a little while because it was some pain trying to get the muscles to come back. But my God, you just stick with it. If you got to get it done, stick with it because you're going to get better. You're going to get better.
Well,
Yeah.
Congratulations. Is there anything you want to say to wrap things up to your audience?
He's the man. Come see this guy.
All right, congratulations.
Thank you, doctor.
You are
God
welcome,
bless.
sir. God bless you. I'm Dr. Deuk here at the Deuk Spine Institute with one of my patients who's traveled from North Carolina because he had some herniated discs in his lower back and he was having problems with the back. What kind of problems brought you to Deuk Spine Institute?
Dr. Deuk, it was severe pain that I had never experienced before, and pain that scared me so much that I thought it was going to change the way I lived. I've got a family and I'm active, and it literally scared me to death. And as I'm talking to you right now, the hair standing up on my neck, the pain that I was suffering and where I thought I was, I didn't think there was going to be an answer.
And you were pretty much bedridden. You couldn't get out of bed. I remember you showed up here in a wheelchair because any standing was causing sciatic type pain in your leg.
Yeah, there was no doubt. And that's not an over exaggeration where I could maybe get up, like stand for 15, 20 seconds so I could get to the bathroom to go urinate, for instance. But then when I got there, I had to lay on the floor so I could rest up a little bit so I could stand with pain to even be able to try to urinate. And this went on for 2.5 weeks. It was absolutely brutal. And there was no respite. Pain that I had in the past, I could find some position where there was some respite from the pain, and there was nothing.
So your wife is a physician. Was she able to fix your back problem for you?
I wish. No, I mean, she consoled me. And in the town that we come from, we know a lot of folks. And to be absolutely honest, we just weren't getting a lot of help. And like I said, we know a lot of folks, and it was prolonged, and we were talking about pain management and all that, and that's just not for me. And like I said, I was scared to death.
The problem with pain management, unfortunately, is that it doesn't fix the issue when you have a herniated disc and back pain from a herniated disc, because you need surgery on that disc to repair it. That's what the Deuk laser disc repair did. You can actually see here that we went into his disc with the endoscope and we were cleaning out the herniation with the laser. And the laser actually makes a huge difference. People say, oh, lasers, they're not used in spine surgery, but they are, and they're very, very powerful tools and very precise. So we were able to clean out your discs, remove the herniation, and how do you feel today?
I feel great. I mean, it's probably, I mean, I know I'm on camera right here, but I literally could not walk into the office yesterday. And I mean, you're gonna see my shorts and everything, you'll have to edit, whatever, but I'm able to walk.
That's awesome.
And I'm just, it wasn't even close. I was actually, and I don't know if you can tell from the camera what my personality is, but I try to be very polite, and I was apologizing for profusely sweating because I hurt so bad. It's not because of the Florida heat by any means. It's because I hurt so bad. I never experienced pain like that. And like I said, there's no
Because
rest.
you're a redneck too. You know, you're not that far from Florida.
That's
you're
right.
just,
That's
just
right.
up a state or two, right?
That's right.
A
Yeah.
couple of states. So you're feeling better today. It's been less than 24 hours since
Yep.
we did your surgery. You went home an hour after the surgery, back to your hotel with
Yep.
your lovely family who I met.
Yep.
And how do they feel about your progress?
They're happy that I'm happy. You know what I mean? Because they were scared too. You know, now they were putting on a strong front, but I am just telling you, I was at my wit's end. And I certainly are a lot more appreciative of people who have pain that I'm aware of, because when there's no rest from it, oh my gosh, you know what I mean? I was really at my wit's end, and you saved me. So I appreciate you very much.
You are welcome, sir.
Yeah.
Is there anything else you want to say to your fans out there?
Thank you. Sorry, I could have pretty up for you a little bit better. So just had surgery yesterday.
All right.
Cut me some slack.
Excellent. And you're heading back home today, correct?
Yeah, right, going back on the plane later this evening. The kids are going to swim a little bit down here in Melbourne. I am just going to rest and watch TV, but then we're going to get on a plane a little bit.
Awesome.
Yeah.
All right. Well, congratulations. You had faith,
Yes.
took the
I have
leap,
faith.
and you got the surgery done.
Yes, sir.
All right. Awesome.
Right, and we're good.
I'm Dr. Deuk, and we have just finished a thoracic Deuk laser disc repair. I think this is number 17 that I've done in the last 2.5 years. So what does that mean? Well, if you look at the spine, there's the neck part, which is here, cervical. Then there's the lower back, which is called lumbar. And then there's what's between, which really is where your ribs come around. And that part of the spine doesn't get injured very often because the ribs really provide a lot of stability and keep, basically keep injuries to the thoracic discs at a minimum. But some people do get thoracic disc herniations and they are painful. And the problem is that pretty much every doctor doesn't know what to do about it. They might try an epidural, they may try pain pills. Nothing works except surgery on those thoracic disc herniations. And the kind of surgery that's used to be done was literally so invasive that I've done them when I was a resident back in 97, 98, 99, 2000 at Shands Hospital. And we would do it primarily for fractures or tumors of the thoracic spine. And literally you have to make a huge cut in the skin. You have to peel all the muscle up the spine, fillet it over, move it over, and then you got to drill away the head of the rib and the pedicle and the facet, and you basically come from the side and try to get the herniation out. Now, we would reserve these surgeries only for massive herniations causing spinal cord damage with paralysis or fractures of the thoracic vertebrae, or some kind of a tumor or mass in the front of the spinal cord in the thoracic spine. Basically, really rare things, okay? But what's far more common are painful thoracic disc herniations. And these cause horrible pain for people, and they have no relief. And the only way to fix them is with surgery. So there are no thoracic spine surgeons that will do the massive surgeries for a small disc bulge or herniation causing thoracic pain. They'll only do it if you're going paralyzed. So they're going to tell you, don't do it, live with it. But these people don't want to live with thoracic pain, and I don't blame them. And now we can fix it because we fix it at Deuk Spine Institute with a minimally invasive endoscopic procedure. And the way it works, basically, I'm going to use a lumbar spine to show you, but the way we do this is we actually come from the side and we go in through that hole that's already here called the neuroforamen, and we get right into the herniation and repair with a laser. What makes it difficult in the thoracic spine is the fact that the ribs come in and attach right where we're going in, but I've been able to do it despite the ribs being there and the transverse processes being there. And I tried my first case with thoracic Deuk laser disc repair 2.5 years ago with a patient. I still remember him, that he was suffering with 2 thoracic herniated discs from an injury, and he had tried epidurals, facets, medial branch block, RFA, everything, and nothing worked. And he told me, if you don't do the surgery, I'm going to kill myself. And so basically he had no other alternative. Pain pills weren't working, therapy didn't work, shots didn't work, pills didn't work. He didn't want to be on the pills either. Long story short, I did the surgery, it went successful. We got rid of his pain 100% in the thoracic spine. And after him, I did more, and so now this is number 16 or 17 today. The problem with today is I couldn't get the upper thoracic disc because the patient was moving around way too much. So we're thinking about bringing him back and doing it under general anesthesia. That's probably what we'll offer him. So I got the T5-6 disc done through the foramen on the right side. It was successful. Clearly it was painful. We did a discogram and he responded to it. And then we just kind of put him to sleep and did that disc repair, and we had to abort the T2-T3. All right, what questions do we have?
Yes, this one question comes from Miguel on Facebook.
Hi, Miguel.
And he asked, do you work with general or local anesthesia?
Miguel, we work with both general and local. We do all anesthesia. There's not a type of anesthesia we can't do. We have a board-certified anesthesiologist who's very capable. If we're doing the Deuk laser disc repair on the neck, we're going to do it under general anesthesia. If we do it on the thoracic or lower back, it's done under local with propofol sedation. Those are just the best choices for the types of surgery. Unfortunately, today we have this patient who we could not do it under propofol sedation because we couldn't give him enough sedation to lay still because he would stop breathing. We can't have patients stop breathing, they will die. So we have to balance the use of the anesthetic propofol with the pain control versus breathing. So it's a safety issue. You never know how someone's going to respond under propofol until you start giving them propofol. This patient did not respond well. So next time, if we're going to try the T2-T3 in the future, we're going to do it under general anesthesia. Any other questions? Hope you enjoyed the surgery. We're done for today. We'll see you next week.